Hi, Manik. I couldn't be more
Hey,
excited to be here with Manik Bhat.
same. Thank you so much, Jacqueline. This is interesting. This is the first time I've ever done this.
This is a big experiment for us.
I know, right?
Um, so we at Acumen have been doing a series internally where that we're calling the moral imagination in crisis, specifically in a time of the coronavirus, where I've been speaking to extraordinary leaders, entrepreneurs, who are not only dealing with the urgency of now with great humility, and focusing on the suffering around us, but already have the audacity and vision to imagine the systems that we need to build. And so today I am deeply excited to be talking to Manik Bhat, an Acumen America investee located right here in New York City, who started a company called Healthify in 2013. Manik essentially, through Healthify, is integrating social services at the community level. Think food services and employment and housing with the larger healthcare system to create a more integrated approach looking at the whole person, and is already proving that in doing that, you can improve health, reduce costs to the health systems. Healthify works in all 50 states and has impacted over 20 million people. And so today we're going to talk about what Healthify does, what Manik and Healthify is seeing at the local community level, at this confluence of class, race, community, and COVID, and how we need to think about retooling our health system in the future. So welcome, Manik Bhat.
Thank you so much, Jacqueline. No, I'm humbled by your kind words and excited to be here and share our perspective. And hopefully this starts a conversation with all the folks that are joining as well that we can all learn from because we're all in this together.
Thanks, Manik. So I just want to start by giving people a sense of who you are
Yeah.
as an entrepreneur, where you came from, why you started Healthify in the first place.
Yeah. So it's been quite a journey. So at a high level, back around 2008, 2013, I was doing community health work in East Baltimore. And if folks who are joining know the East Baltimore community, it's a community with quite a bit of need. I was at a pediatric clinic, a community psychiatry clinic, primarily working with high needs families in Medicaid and Medicare, and was on the front lines and found and saw day in and day out the biggest needs families had were social needs and not clinical needs. It was food, housing, transportation, access, childcare. Those were the needs that mattered. Those were the needs that really impacted outcomes. And from a transcendent perspective, were really the needs that impacted the ability for that family to thrive and seek opportunity in their own lives and their own community. So when we were on the ground, we saw this and felt that the health system we were a part of, which is a phenomenal system, we were failing these families in a lot of ways. And quite honestly, a lot of the work grew from frustration. We felt that this is the elephant in the room when we're talking about healthcare and reducing the cost of care, and we think about building stable communities. And we decided that while there's no magic bullet to a lot of these issues, and we'll talk about more of them throughout this conversation, we felt there's definitely ways we can connect families to social services more effectively and build a sustainability in that sector that we need based on the unmet need that is actually out there in vulnerable populations. So that really set us on a path on this journey to say, how do we build scalable and sustainable solutions in this space to connect families to social services and work with health insurance companies, health systems, the public sector, community-based organizations in a way where they're all connected to serve families the best in a way with high degrees of dignity and value, ultimately. And it's been, we're now at a point, we've been on this journey for about 6 years now and are finally seeing some of the fruits of our labor, which is great. In the early days, it's hard to see where is point B going to end up. But I think the time we're in today, which I'd love to talk more about, quite frankly, is just shining a bright light on the infrastructure challenges between healthcare and social services that all of our attention is focused on right now.
Thanks, Manik. Yeah, I mean, this crisis has exposed the gaping wounds of this entire system in healthcare and what that means. You've been a huge advocate for what's called the social determinants
Yeah.
of health, and have said that in a way we've been misguided by focusing only on clinical health and how we solve for it. Could you just really explain what that means
Yeah,
and how we need to think differently.
yeah. So there's a couple ways to look at it. Simplest way, it's the environment in which we live, work, and play that have direct impacts on health outcome measures. So our access to healthy and nutritious food, our access to transportation, stable home environment, access to stable income, all of these things, which has now been validated to drive about 40% of our overall health outcomes versus something like clinical care or access to going to your doc. So the outsized impact of zip code versus genetic code is there. And the number I always quote that shows the gravity of the situation, in the zip code where I worked in Baltimore for a couple of years, if you move 2 zip codes to the right, the life expectancy difference, and I use life expectancy, it's not a great measure, it's a really rough, raw measure, but I think it paints the picture. The difference in life expectancy was 20 years. So you think about the loss of potential with a 20-year delta of life expectancy from a 2 zip code difference, and you recognize this is what we need to be focused on as a healthcare system. And then from an economic standpoint, we always hear the refrain that we're spending a lot on healthcare. And the interesting thing when you look at the numbers is when you add our percentage of healthcare spending as a percentage of GDP plus social services spending in the US, the total amounts across both those things is actually pretty comparable to other nations that perform better on some core metrics. We're just very much flipped. We're spending far more on reactive healthcare than proactive community health and social services, where we would get a lot more value and serve families a lot more effectively from a double bottom line perspective if we focus more upstream.
And so what are the opportunities? Well, first of all, could you just give some examples of what's going on in the country today?
Yes.
You are connected to many food banks, for instance, as a way of looking at COVID. So could you just talk about the crisis, how this is
Yeah.
manifesting itself at community level?
Yeah. And we've been looking at this from 2 frameworks. One is based on timeline and one is based on first and second order effects. So I'll walk through both perspectives here. So first, when we look at time periods, we're looking at what was happening pre-quarantining efforts, what's happening as quarantine began and continues, and what does long-term recovery look like. So we knew already that pre-COVID-19 and the crisis and pre-quarantining efforts, there was already capacity constraints in the social services sector, right? So that's been the status quo. There's been funding and capacity issues across key domains for social services for quite some time. Now, as quarantine began, we saw a huge spike in unemployment, which we're all aware of, and a lot of workers are furloughed, and that's falling directly across racial and ethnic lines in a lot of vulnerable communities. And what that's prompted is a dramatic spike in need for food and childcare. So we have a spike of demand for food and childcare right as quarantine began, because a lot more folks need those services, and the unmet social need is more apparent. And the sad kind of tragedy that we're seeing is a lot of the community partners that are delivering these services are really struggling because they don't have the capacity to meet that need. So many of them are closing or reducing services during quarantining due to either lack of funding or, more importantly, lack of volunteers. And we'll talk about what folks can do to get involved, because volunteer capacity is a big concern in terms of how community partners are struggling right now. The number I always share is, here in New York City, we have close to 200 food pantries that are, New York City has a really powerful social services sector. But last we saw about 30 to 40 of them have already shut down. So when you think about that system failing on the capacity side and the demand side increasing, it's not a good news. Now, as quarantine ends, what we're in certain areas or
Wait, Manik, before you go there,
yeah,
when I was jogging the other morning, I saw lots of food lines, and where there were food lines, in Chinatown particularly, there were signs that said, New York City is committing to 3 meals a day if you need them.
Yeah.
How does that system work?
So there is in New York City a lot more funding recently coming in to support the food delivery system. What's tough right now is volunteers at the food banks in New York City and how the delivery model for food banks and food pantries is changing. Due to a lot of the social distancing efforts, volunteers aren't readily coming into these food banks, and a lot of these long lines, of course, introduce a high degree of risk for the most vulnerable to begin with. So not only are they are we dealing with a situation where folks are out of work, but also to receive social services from a brick and mortar standpoint introduces a higher degree of risk. When you layer that on top of the other aspect of social needs, which is we know there's a clear link between unmet social needs and chronic illness, and we know there's a link between chronic illness and worse a likelihood of success in recovering from COVID-19, it ends up building this kind of chain of negative events in a lot of vulnerable communities. So a lot of food banks are now, this is not happening more in New York, but in some other communities we serve, they're trying to transition their brick and mortar models into virtual models or delivery models, where the food banks are working with ride sharing companies, and we're a part of this work out in Kansas City that I'll talk about, where they're delivering food to vulnerable populations. And most interestingly, what I think is another interesting second order effect, low-income students who are primarily receiving food at school are now also able to access some of these food delivery services as these food models are changing and need to change their delivery models due to the current quarantine efforts. And that's some of the creative solutions we're seeing in terms of people rising to some of the emerging challenges that are occurring right now.
I love that. And that is where is that happening?
So that specifically, that work is happening in Topeka. So we're partnering with a company called Ride Health, and we're working with a couple other organizations there in the Topeka School District, where specifically the idea is 15-day delivery meals, contactless delivery from drivers using the existing NEMT and transportation benefit structure in that community and repurposing it specifically for meal delivery for vulnerable populations, knowing that demand is higher, knowing that a lot of these community partners can't deliver in the old model.
It's amazing. So just to unpack two things. One is that the traditional volunteers at these food banks tend to be the vulnerable populations themselves.
Yeah. The number is over 60% of volunteer capacity, and majority of community partners are the elderly, which are most at risk.
And so how does that change now in terms of, are young people taking risks and going out? One, and two, then on the ride share, I just want to have you unpack. I mean, you're at the middle then of the private sector, the public sector, social service organizations, and government. And who coordinates? I mean, this is a true collaboration event.
Agreed. And I think, that's somewhere where we see our value is kind of the translator between all of these different sectors from a technology and capacity building and people perspective. So we, provide, here's the layer of technology to help coordinate this information logistically. Here are the relationships and funding streams from a governance and incentive perspective to actually make this work. And then all kind of in it together to actually see the results and track the outcomes of progress. But our model from day one has been, this has to be an involvement of health plans, health systems, community partners, and the individual family at need at the center of this to actually make the work sustainable long-term. Because we feel some folks have the trust of the community. Some folks have capital to help scale solutions and impact. Some folks have the actual people on the ground to actually help. And I think only by using the existing tools and existing creativity and resources we have in a kind of more creative way can we actually bring something to bear at scale quickly.
Well, so I want to get back to this because what you're describing, Manik, is moral leadership. And that's something that you really epitomize as well, that you've been driven by solving a problem, not just by making money or being, some famous guy. But someone just sent a question in asking that saying that they would like to volunteer, but they're concerned about the risks. And so do you have any ideas for somebody like that?
Yeah, no, it's a good segue into how we think about what happens in long-term recovery. So we know that shelter demands are going to increase as evictions rise. We know that food demand is going to remain elevated. And we've seen, as I mentioned, a lot of these organizations changing delivery models. But another big aspect that's not being talked about is social isolation for seniors in this time and after this time. And there are some really interesting organizations right now that are really structured in a way where there's contactless support for seniors, where you can hopefully get on a conference. And of course, this is limited to a certain population, right? Not everyone can have internet access and ability to actually conference via video. And that's something we can talk about as well. That's another determinant that I think is going to be even more apparent when we get out of this, when 30% of the US population doesn't have access to broadband internet and is primarily working off mobile data usage plans that can't support things like this. However, saying that, I think it is a way to help. That is a very low risk way of volunteering, spending some time with seniors, talking to them, more isolated than in the past, which can have dramatic impact on their health and mental health and well-being long-term, and even impact on life expectancy when you look at the numbers on how social isolation can really affect seniors late in life. And I think, and that's something that I'm deeply concerned about, because I feel like it is, it's this weird thing where we are purposefully staying away from seniors in our life, and sometimes our parents, out of care for them. And at that time, we need to find other ways to extend the hand and communicate. So I'm happy to share a list of those organizations that are helping coordinate some of that work. Another great organization called Invisible Hands, specifically doing work in New York City, is supporting with meal delivery to seniors. It's contactless. It's a system where people can sign up to deliver not only meals, but prescriptions, which is another big need that people aren't seeing, is folks who can't access the prescription meds need some sort of delivery option. There's not a lot of stability there in that infrastructure yet either, and that's another great way to volunteer and spend some time.
That's great. So we will probably both on Healthify and on my Instagram feed and Acumen's put up a list then of all the different ways that you can help. So there's give money, there's call people, there's deliver food. How many companies are starting to step up to this effort in terms of when you think about ride shares? And I love that Topeka is at the forefront of innovation here. Are other states learning? Is there?
They are. And what we're seeing in another list we'll share, because another way to help is just through direct funding to rapid response funds. So a lot of communities are starting rapid response funds that are tied either to the local United Way, which is connected to a lot of the social services in the area. And we have an aggregated database of all these rapid response funds that people can access. We'll be sharing after this conversation. So that's one specific opportunity that I think would be valuable.
Great. Manik, I've been so gutted looking particularly at the South, at southern states, either where there's still not social distancing and sheltering at home, where there is no Medicaid connected to Obamacare, and where the numbers are just getting worse and worse. I think in Louisiana, 70% of the deaths are in the African American population. Just stunning in terms of what this is exposing. If you could say a little bit about that, but also what you stand for is standing up and lead, and where you are seeing, besides Topeka, some examples of real leadership. So both a commentary on where we're seeing the worst and how do we get a sense of hope from there, and then where can we lead?
I think we're seeing people come together and rally in all areas. Some folks, there's actually another site we'll share of a lot of folks spending their time, and if there are any folks who are technologists in the audience, spending their time and resources and experience building unique emergent solutions that address the supply capacity issues at the community partner side and the clinical capacity side, which is obviously the main topic of PPE and other necessary items.
All right, Manik, I'm going to stop you right there. The when you talk about the supply on the supply capacity, could you unpack that for people, for the listeners? Because I think that this group that's listening to you, everybody is asking me, how do I help? How do I help?
So from the numbers, what we're seeing from individuals in need, there's an uptick in food, emergency goods, and transportation. So emergency goods are primarily coming from a lot of nonprofits and social services that are delivering those. Those community-based organizations are dealing with significant supply constraints of even having the goods to distribute, let alone the other supplies they need to deliver their core services like food. On the health sector side, obviously the main topic of conversation is necessary and capacity needs tied to protective equipment for really, honestly, quite frankly, the heroes on the ground in the front line doing this work. I think the good news is there's a lot of activity and support on the clinical side and the first order effects of individuals who need protective equipment. A lot more work needs to be done. I think what's going to be worrisome, going back to your comment around what happens in the South and other areas, is the first order effects of hospitalizations or deaths and the percentages are closely aligned with chronic disease in the most vulnerable communities, and that's proving out in the numbers everywhere. And it's a pretty harsh set of numbers. The second order effects of folks who already had unmet social needs, that's where we think the attention needs to be focused heavily, because we feel like the strain that's going to be introduced due to these second order effects on community-based partners is going to be massive. And when I look at, how do we confront, going back to your question, Jacqueline, how do we confront the reality of what's happening in certain areas in the US? I think the silver lining in how we interpret this is we're hopeful that this is going to really push us to change how we approach health writ large and understand there's much more health to healthcare, and realize that there's real capital and investment needed in community health because our fates are much more connected than we previously realized. And I think it's going to push us to reconsider what we value. It's not so crazy to say that childcare is needed and evictions can be avoidable and paid sick leave can be a reality, and there can be a pause on medical and student debt because we're doing it today, right? So I'm hopeful for what the policy implications are, and the change in dynamic in perspective in how close these things can be to a reality. But that doesn't take away from the tragedy that's happening right now. And I honestly don't have a good answer. I think for us, what we're trying to do is work closely with some of the health plans in those areas, in rural areas, that just most recently adopt social distancing efforts. And they're recognizing that, after we come through this, Medicaid is going to dramatically expand. And those states don't have Medicaid expansion, which is another big concern. I wish I had a better answer for the short term, but I think how we've been approaching it is how do we start putting things in place to really support going forward?
Well, I actually hear that you do have an answer, in that one, in that you're doing it. But what I'm hearing through all of your words is one that, and it's connected to policy, but one that we need to get emergency grant funding ASAP, whether it's through government or through philanthropy or through each of our own contributions to these social service providers, be they food banks or housing for the poor or child daycare, so that we can actually start to bolster the existing systems that right now are running out of cash and are so 100%. Critical.
100%.
To what I'm hearing you say, and maybe this is something we can all think about, but how do we share these stories of cities like Topeka that are pulling together the different players? Because this has got to be a national effort. So, and then three, what are the simple things that we as individuals, whether it's just making a phone call or whether it is actually taking a risk and delivering the food to different people, on bicycles, it doesn't have to be a ride share. So I'm actually if I listen to you, I actually think you are bringing forward really great ideas. I want to go to policy though, because when I hear our policymakers, let's forget the policymakers. When I hear our politicians speak about healthcare, this is one of the hottest and angriest topics. And you either have the revolution break down the system, it's completely broken, and people there who sit there might look at you and say, nice stuff, Manik, but you're depending on charity and incrementalism in a system that is too far gone. And on the other hot side, you're seeing people say, our health system is already too generous. If you were king, let's forget about president for this moment. If you were king, how would you redefine, and where do we need to move toward in reimagining our health system, given what we got as a country?
And that's kind of one of the things that has energized me about our work for many years, is that what we're presenting a view on is, no matter what political affiliation you ascribe to, it is not only the right decision from a health outcome perspective to address social needs as a component of healthcare, but it's right from a financial perspective to address these needs as well. So our approach has always been, how do we, whether we live in a public option, single payer, or live with the current status quo, how do we make sure that we redefine what health means and fully bake into clinical care the social needs that are driving 40 to 50% of our health outcomes to begin with? And we think by doing that, the outcome improvement we see is going to be tremendous. Now, I'll caveat and say that I am a proponent of a lot of the public option and single payer opportunities that are out there, because I think they address a lot of the other administrative issues and incentive struggles in the healthcare system at large. But we view that a root cause, a lot of the crisis, is that we're looking at health with a very unidimensional view. We're not understanding the holistic picture of an individual, and we're looking at them only from the four walls of the clinical setting, where we realize that their health, their ability to manage their health, their ability to support their chronic illness, their ability to caregive for folks in the home, is all dramatically affected by all of the needs I talked about earlier. And if we're to path forward, no matter where the policy falls or what's pragmatic or possible in the next administration, we feel pretty strongly that we must have the infrastructure in our communities to support families around these social needs.
So one person sent in a question, Manik, saying that even listening to you, when you look at some European and Asian countries that do have single payer public health, they are nonetheless having much better outcomes than we are.
Yep.
And so how do we get to the nuance that you're talking about in ways that that our nation could actually move on?
Yeah. So I think when those nations have that, and they also have juxtaposed that with a really strong social services sector.
That's right.
And that plays a pretty large role. I still think when you dig deeper, there's still some coordination issues, especially when we see how different NGOs are supported in other nations abroad outside of Europe. But we look at the total amount of spend, and many of those nations have a really strong and robust social services sector. That's what we propose. We propose a lot of the funding that's currently spent in healthcare needs to be distributed downstream to communities and community health with a social services bent, because it's better for outcomes and better for cost. And I think a lot of other nations have recognized that, and also full force said healthcare is a human right, and let's build a structure that allows for that to happen. But I think you need to have both at the same time. I think to extract and see the value and serve families and people in the right way, you need both. You need a strong social services sector to support folks with key needs, and you need access for healthcare for all. And ideally, you need them integrated and tied together, because they are very integrated when you look at how outcomes manifest themselves in someone's life.
So it's a reimagination, not just of the government systems, but all of our systems, and not reimagining them one by one, but within a more integrative ways. There are lots of questions about the how. What are the incentives? How do we get there? And you have all of 2 minutes. So,
well, the good news is, and this is what's amazing, is the good news here is this is happening. So in Medicare Advantage, their health plans now can pay for supplemental benefits, and those supplemental benefits can include things like meal delivery for seniors. A big part of what we try to do at Healthify is show to a health plan or someone who's financially at risk for someone to say, if you have someone who's in critical housing risk and you connect them to a housing program, or you have someone who has a childcare need or needs access to a better income and needs workforce development, the long-term financial impact for you is significant, that it makes sense for you to invest here versus anywhere else. And building that narrative actually drives the incentive for the folks who are financially responsible for the individual, primarily in Medicaid and Medicare, the health plan, to actually make these sorts of investments, which is really how we've thought about scaling the organization to begin with, is aligning incentives between these folks and community health organizations. And in a sense, it makes a ton of sense. One example I always share is looking at folks who are presently homeless. one number that's always talked about, which is a very rough way to speak about that situation, is ED utilization. How many times does someone access the emergency department? And we know that folks who are homeless access the emergency department quite often. And then you look at the numbers. The cost to the health system and the external cost can be anywhere from $50,000 to $100,000 plus. If you give them a home, if you house someone, it costs a fraction of that. Mm. So it's, what are we doing? It begs the question, right? Why don't we spend our dollars more effectively? And that's the narrative and the data we're trying to share, so people can make those types of judgments and investments calls that make sense across every perspective you look at it. But yeah, does that help?
I mean, it's so exciting to talk to you, Manik. I mean, we didn't even get into the kind of data that you are collecting as Healthify, and how you're translating that into a reprioritization of the critical places where we should be putting our spending. Because I just want to go back to the very beginning where you said that the United States actually spends more on most other countries anywhere on the planet when it comes to health plus social services. But the way that we're spending it is not working. That this virus, more than anything, has shown that if we do not take care of our vulnerable, our poor, the whole suffers, not just them. And that is something we really need to change and to fix. You are also just such an example of the power of social entrepreneurship, somebody who's been driven to solve a problem. You are not ideological. You're just focused on how do we bring these sectors together, government, private sector, community, social service, in a spectacular way. And you've got the data to show us where we need to make change. And it's why, at the end of the day, what we're focused on most is moral leadership. And you are just such an example of a leader that puts humanity, Earth, at the center of everything you do, and not simply profit. And yet you insist on finding sustainably financial ways to make this happen for a better world for all of us. And I just can't thank you enough for the work you're doing every single day, and for all that you brought today to the conversation.
Thank you, Jacqueline. I mean, I could. The amount of respect I have for you and the Acumen team is tremendous. I think y'all are doing phenomenal work, especially at this time. And I just appreciate the opportunity to share some thoughts. And if anyone's online, feel free to reach out, and we'd be happy to connect you to folks so you can get involved in support as well.
Well, thank you. And just the best wishes to you as you go forward.
Thank you, you too.
And anybody who wants to sign up for any or to help, as I said, Acumen, myself, and Healthify will all put up lists of where you can contribute. Take good care.
Go. Thanks so much, everyone. Take care.
Bye.